starting with Dr. Nishikal.
Good evening, everyone. I'm Dr. Nishkala, final year pathology PG from Osmania Medical College, Hyderabad.
Okay, next.
Samarathinam, President 3 from Pathology from Tata Memorial Hospital, Mumbai.
Good evening. I am Dr. Pushpit, PG third year from Malana Medical College, New Delhi.
Good evening. I'm Dr. Nasiha, second year PG resident, Uttar Pradesh University, Safai Tower.
Good evening. I'm Dr. Nair.
Good evening. I'm Dr. Chinmayi. I'm second year PG from Yenapaya Medical College, Mangalore.
Good evening. I'm Dr. Nida from Ramya Medical College, third year postgraduate.
All of you introduce yourself. Now I request Dr. Niti Matthews sir to kindly take over from here. Please start sharing this presentation.
Thank you. So I'll directly try to share my presentation and we'll get started.
Yes, sir. This is
All right. So I believe the slides are visible and I'm already left, so I'll get into it straight away. So let's start with the case scenario. This is a 25-year-old lady seen in accident and emergency with chest pain and shortness of breath. She was on aspirin and had very recently stopped oral anticoagulation on advice by her physician on a review visit 2 months back. She was started on warfarin by her physician for a period of 3 months and on aspirin after she developed left superficial femoral vein thrombosis in the third trimester of her first pregnancy. This thrombosis event was confirmed by compression ultrasound. Her pregnancy was complicated by preeclampsia requiring a preterm delivery. This lady's family history: she has one uncle who was diagnosed to have borderline antithrombin deficiency that led to central laboratory when screened for thrombophilia. He had a severe sharp chest pain during an episode of febrile illness, which was diagnosed as segmental pulmonary embolism on chest X-ray, never followed up as he was left on lifelong anticoagulation by the same physician. A cousin had complicated pregnancy, and another cousin is being treated for Cori DVT by another physician in the same town. Our primary case, index case, was never investigated for any thrombophilia risk factors. Now, this is our case, the pulmonary angiogram. So there are no prices for the diagnosis here. This is a massive pulmonary embolism. So she underwent the pulmonary angiogram to confirm the clinical suspicion. Now we know that this is a very expensive and invasive test. So from hearing this history, basically her history, her family history, is there something wrong here in the management of the venous thromboembolism episode? That's the question. Basically, has the laboratory been underutilized? So basically, we're trying through this case, we're trying to understand what is the role of laboratory in thrombophilia testing and treatment. So one thing is to identify the risk factors or individuals at risk for thrombosis. So evaluation of the underlying hypercoagulable state or a thrombophilia workup. Identifying individuals who are at higher risk for recurrent thrombosis or rethrombosis, and provide useful ancillary data for the initial diagnosis with tests like D-dimer. And of course, how do we monitor this antithrombotic therapy? Now let's look at the possible errors in the way this case was particularly managed. So she was on aspirin and had stopped warfarin. Now this is a case of recurrent thrombosis. We know that she had this left superficial femoral vein thrombosis confirmed by compression ultrasound, basically on radiology, and it was not an arterial event. Yet she was on aspirin and warfarin was stopped. We also know that she had a complicated pregnancy by preeclampsia, which required delivery. That's her case, which was probably not correctly managed. Now coming to her uncle, he was diagnosed as borderline antithrombin deficiency at a centralized laboratory when screened for hemophilia. Now this is not confirmed. Now the rule is when you have a deficiency in one of the procoagulant factors such as beta antithrombin or protein, whatever, you need to, once any of these are deficient, you need to repeat this at least once to confirm that it is actually low and it was not transient. The other thing is pre-analytical errors, as you have learned probably in your previous exercise, is also very important in diagnosing coagulation thrombotic disorder. So now this particular uncle was supposed to have, it was said that he had a segmental pulmonary embolism on chest X-ray. But the point is, it was taken at the time of his febrile illness. So there's also a possibility that he had a pneumonia, which was probably mistaken to be a pulmonary embolism. The other thing is, he was never followed. Based on that event, he was left on anticoagulation, which is lifelong. He was not followed up. That leads to an increased risk of bleeding. So there was a pulmonary angiogram to confirm the clinical suspicion and over dependence on radiology basis. So the use of laboratory in this case scenario provide useful ancillary data for initial diagnosis. In this case, there was no laboratory data that was given. We just went by radiology, so that was not done. Monitoring antithrombin therapy, two mistakes here. Uncle was left on lifelong warfarin, unmonitored, and this, our case is only on aspirin despite having a venous thromboembolism. So individuals who are at higher risk for recurrent thrombosis, this particular case is our case is having a recurrent thrombosis event within 2 months. And identifying the factors or individuals at risk factors of thrombosis so that you have to evaluate for underlying hypercoagulable state, which is a thrombophilia workup, not done on her very clearly, but done on his uncle after his query VT, which is also not confirmed. So a little mismanaged this case. So it is usual practice to treat patients with a finite period of anticoagulation, at least 3 months after the first episode of venous thrombosis. And after the first episode of VT, patients are 40 times more likely to suffer a further event compared with previously unaffected individuals. So these are all statements from standard papers. Recurrent DVT is a major risk factor for post-thrombotic syndrome. Recurrent DVT increases the risk of chronic thromboembolic pulmonary hypertension more than 10-fold, and preventing recurrent VT significantly reduces the burden of disease. Recurrence on treatment is not more likely in patients with heritable thrombophilia, which means even if it's a heritable thrombophilia, the risk of recurrence is not higher if you're on treatment or prophylactic anticoagulation or therapeutic anticoagulation. Testing for heritable thrombophilia does not usefully predict likelihood of recurrence in unselected patients with venous thrombosis. And cohort studies have demonstrated a low risk of primary events in asymptomatic relatives or affected patients with factor V lesion or prothrombin mutations, which are some of the most common known mutations for thrombophilia. So it became apparent that these tests typically had no clinically useful predictive power. So then, perhaps in limited situations, thrombophilia testing in asymptomatic relatives may be useful. For example, women who intend to become pregnant and in individual cases of women who would like to use oral contraceptives. So there, because oral contraceptives per se, as in the next line you can see, has a higher risk of VT compared to the general population, 0.7 versus 0.03% per year of use. So a negative thrombophilia test may lead to false reassurance. That if you get your negative thrombophilia report, you can have a false sense of security that I will never get a thrombotic episode, which could be false because it could be a temporary thing, or at that point of time of testing, it would have been normal. So there's a different approach now to thrombophilia workup. The emphasis has changed. Now we are looking for tests that predict the risk of recurrence and can even identify patients that benefit or not from long-term anticoagulation. So basically, we are looking for a test that will tell you whether a clot is present or not. It's basically an investigation for a clot. Now, clinical evaluation is very subjective and followed by a radiographic method, which is quite objective. So, like we saw in our examples, the DVT, compression ultrasound, gold standard invasive method, and ventilation perfusion scan for PE, including newer methods like spiral CT and all. But of course, as we all know, especially in our cost-limited settings, disadvantages are the cost. These are time-consuming, may not be available 24/7, require special personnel, potentially risky procedures, and somewhat poor sensitivity. The other thing is, 75% of people who present accident and emergency or the OPD with some symptoms that might go in for these investigations end up not having a DVT. So there needs to be an inexpensive test which could be utilized to eliminate some of the patients without VG. So the main culprit in a venous thromboembolism is thrombin or the thrombus or the clot. So thrombin generation is there, means clot is generated. So there are several markers of thrombin generation. There's a whole list here. I'm not going to talk about that because actually among all these different products of markers of thrombin generation, only one is helpful as to date, and that is the D-dimer quantification. This is supposed to be the ideal screening test for a clot which we are trying to find out. So D-dimer is a unique marker of fibrin degradation that is formed by the sequential action of three enzymes, which is again starting with thrombin, the clot per se, factor 13, activator factor 13, and plasma. It's a 180,000 Dalton protein with a half-life of around 4 to 8 hours. When we talk about general qualities of a screening test, the test should be able to be done in a short time, comparatively little effort. It should be cheap, sensitive, and serve as a selection procedure for further specific investigation. So when you look at all these qualities, D-dimer usually fits the bill because it can be done faster and it's quite sensitive. And basically, it has much more negative predictive value. We'll come to all that. And it has been in use over the last 3 decades. So if you look at a paper from 1991 in Lancet, you can see how in patients with pulmonary embolism, how the D-dimer was significantly higher compared to the other group which did not have the disease. The techniques for D-dimer measurement, you have many platforms available. So you have monoclonal antibody and you have platforms which target a specific epitope on the D-dimer molecule. ELISA is there, but you know it is time consuming. There's overnight incubation, you need a reader, so on. People have moved on to latex slide agglutination. It's a semi-quantitative, it's rapid, but it's less sensitive. Then there's of course automated latex agglutination method, rapid and sensitive. Now you also have the CLIA platform, which is the chemiluminescence immunoassay platform, which is again highly sensitive and rapid. There are also some.
Sir, your voice is not coming.
Okay. Can you hear me now?
Yeah.
Okay, so I think I have a net issue. I'm just stopping my video for a bit. I'm still audible, right?
Yes.
And my slides are moving as well. I mean, right now it's on the D-dimer unit slide.
Yes.
Okay. So I will continue because I got a network error. All right. Okay. So when we talk about D-dimer units, now the same value can be reported in different units. So we need to be aware of that as well because we might have a number in mind as this is normal for D-dimer, above this I should call it abnormal. And suddenly you find a number which is 10,000 times lower or 1,000 times lower or 1,000 times higher. You may get a little confused. So for example, let me start from the very bottom. That's what we follow in our lab is using the unit of nanogram per ml. So we say above 500, we have to think about it as some term significant, but it is actually the same as in milligram per liter, it is 0.5. And this nanogram per ml, when it comes to microgram per liter, it is still 500 because the unit of the denominator change. So like that, we have to keep in mind that it can be reported in different units and therefore the value can change accordingly. When we talk about reference interval, for example, you have a test like a PT or APTT, you have to establish a reference interval in your lab, which is basically the lower end and upper end, and within that level, anything is normal. So when reference interval is usually established by saying specimens that are obtained from healthy individuals, whereas the cutoff value is established by reviewing high-risk candidates that undergo objective testing. So D-dimer is one of those where you do not have reference interval, but instead you have cutoff value because there is nobody, we cannot say that this is normal D-dimer. We can only say that if it's high above the cutoff, it might be significant. So cutoff value for majority of this will be more than the upper limit of a reference interval. So that's when you have a cutoff value will be definitely higher than your upper limit of a reference interval if you use it that way. So is the utility of D-dimer? So it can be used to exclude a venous thromboembolism. So once you have D-dimer above a particular cutoff, those may be subject to imaging testing. The other thing is, if you use D-dimer alone too, it may not be very safe in the sense you might miss some cases which are still not reached that level. Then the determination of D-dimer after a negative imaging test. You may require too many unnecessary imaging tests because if you're waiting for the imaging to come negative to do a D-dimer, might as well first do a D-dimer, which is a simple laboratory test. Next is determination of D-dimer combined with the pretest clinical probability. This is probably the right combination of way to decide whether a person has a risk for a venous thromboembolic event or a venous thrombotic event. So the clinician's prediction tools. So there are some scores, for example, what ensures that the test increases specificity. For example, using a clinical score like the Geneva score for the assessment of clinical probability of pulmonary embolism. You can see there are different parameters which are given different scoring points, and at the end of it, you look at the clinical probability. Is it a low probability or an intermediate probability or a high probability by looking at the total of the score. Similarly, there is also, for example, this is a modified Bell score. You can look at for DVT, you have some where is there an active cancer, is there tenderness, calf swelling, all the things out major diagnosis, and you give a score. For pulmonary embolism, you look at the heart rate, previous DVT or CE, hemostasis, malignancy, and like that you give a score. And again, look at the probability is it low, moderate, or high. So if you combine this with your D-dimer test, you increase the specificity of the score. Now, D-dimer of venous thromboembolism, you combine the clinical probability and D-dimer, you have a symptomatic VTE case, look at the D-dimer. Now, if there's a negative D-dimer and a low clinical probability, that's enough to exclude a venous thromboembolism. Whereas with that and a high clinical probability, probably you need further investigation to make sure that he does or doesn't have the disease. And if there's a positive D-dimer, of course, you need to have further investigation to see what is the chances or the possibility for the person having a PE or a DVT. So in pulmonary embolism, the combination of a low clinical probability and a negative D-dimer test effectively rules out PE. In patients with high clinical probability, D-dimer has a higher negative predictive value than the Wells probability rule, and combination of both further improves the diagnostic value. So it's always better to combine it with the clinical probability rules. Plasma levels of D-dimer are proportional to usually to the severity of pulmonary embolism. So you can even find levels, once you have levels actually in this range, more than 20,000, it could predict adverse outcomes better than assessed by any radiological biochemical or even clinical criteria for that matter. Which means when you have levels like this, you can actually be sure that the patient is definitely at a higher risk. So when we talk about recurrent DVT and the test to predict recurrent DVT, you look at articles even from a little dating a little back, D-dimer testing, the utility in the duration of anticoagulation therapy. In that particular study, 608 patients with first unprovoked VTE, 3 months of oral anticoagulation, D-dimer levels obtained 1 month after cessation of anticoagulation, and patients with normal D-dimer did not resume anticoagulation, and patients with an abnormal D-dimer were randomized to not or resume anticoagulation. And then they looked at the outcome rates. Now it is very clear that abnormal D-dimer levels without anticoagulation clearly had the worst set of outcomes as opposed to the lowest or the best outcome were those who had abnormal D-dimer levels but were on anticoagulation. And then there were normal D-dimer levels, therefore were not put on anticoagulation. They were even at a further higher risk than those with abnormal levels with anticoagulation. Thus telling you the utility of this particular test in telling you who fares and how they fare in this particular scenario. So during follow-up of this group, the incidence of recurrent VTE was 15% in those who discontinued the drug and just under 3% in those who resumed anticoagulation. And adjusted hazard ratio for VTE recurrence among those with abnormal D-dimer level was 2.27. So furthermore, there are more articles which tell you how the D-dimer at venous thrombosis diagnosis is associated with the risk of recurrence. So I'm not going to the details of this very busy table, but just to tell you that this was one where they categorized the patients into quartiles based on the D-dimer levels, which is something like this. 0 to 1,500 is quartile 1, and then 1,600, 3,000, 3,000 to 10,000, and more than 7,000. And they looked at the incidence rate and the hazard ratio. You can see that how anyone that's 0 to 1,500 has the least incidence rate and hazard ratio, and how it increases as the D-dimer goes up. So basically, putting it all together, they actually in the second exercise they put Q1 as one category, that means anyone less than 1,500 D-dimer, and all the others together they clubbed it together and looked at the recurrence rates, etc. And the crude incidence rate was 1.5 per 100% years in the lower quartile, which is Q1, and it's 1.7 versus 4.9% in the upper three quartiles combined, which is making an absolute risk difference of 3.2 per 100 per year. That is evident in the tabular form as well. This is the quartile one with minimal incidence of recurrence versus the other two groups, however you look at it. So the summary of that study was that the D-dimer value less than 1,500 has a substantially lower risk of VT recurrence compared to patients with a D-dimer more than 1,500, and the association between low D-dimer and recurrence was particularly pronounced among patients with incident DVT and in patients with a first unprovoked VT event, who had a 69% and 60% lower risk of recurrence, respectively. Findings suggest that a low D-dimer measured at the time of VT diagnosis may aid decisions on short-term treatment, particularly in patients with unprovoked VT, and the recurrence rates observed in the lowest D-dimer category, that means those who had less than 1,500, were similar to the rates among patients with normal D-dimer. Now the remember no reference interval, cutoff we take for D-dimer being normal is less than. Actually, in a normal person, we expect it to be less than 250, but to call D-dimer abnormal, it should be more than 500. So we are saying this in among patients. So among patients, if you have D-dimer less than 500, we take it as normal. In studies that measure D-dimer after treatment withdrawal. So again, coming back to our case, in the clinical scenario that we have, the uncle was left on lifelong warfarin unmonitored, and we were not even sure whether he had a pulmonary embolism. And the lady in question is only on aspirin when she definitely had a VT. Now we already know that this aspirin is for the white clots, whereas an arterial thrombosis induced by platelets, whereas venous thrombosis is by the red clot. Now our patient clearly had a venous thrombus as was proven by the compression ultrasound, but she was only on aspirin giving antiplatelet agents, and for the red clot you needed warfarin, and she was taken out of it, or you needed something like heparin. So basically, it is identifying those factors of individuals at risk for thrombosis. They need to do a thrombophilia workup, which was not done on her, which was a mistake. And identifying individuals that are high risk for recurrent thrombosis, this lady clearly had. So she had a venous thromboembolism, proven. She had a preeclampsia during a pregnancy, so she had a current event of PE. So she definitely has a recurrent thrombosis within 2 months. And the ancillary data, which would have given this clue at the initial point itself, the D-dimer was not done. Rather, they chose to go by high-end imaging methods. And of course, the monitoring part we already covered. So the take-home point for this particular scenario and presentation is that you cannot do without a D-dimer. D-dimer, as measured by a sensitive test, can be safely used to exclude VT in symptomatic outpatients, provided that it is used in combination with the pretest clinical probability, which increases the sensitivity and specificity to a much higher rate. High concentrations of D-dimer are associated with an increased risk of recurrent VT benefited by prolonged anticoagulation, and predicts the severity and outcome of PE, needing more intense management and prolonged anticoagulation. Patients who present the D-dimer above the cutoff after stopping the regular course of oral anticoagulation may benefit from extended prophylaxis. So again, D-dimer has a role in predicting those patients who might benefit from extended oral anticoagulation as a prophylaxis. So that's it about this particular presentation. Any particular questions you have on this? Because I'm going to stop this. And yes. Hello.
There are no questions on the chat box, sir.
There are no questions. Did I hear that right?
Yes, there are no questions.
Right. So in that case, I will go into my second presentation, which have come up. So that was the case from the thrombosis side or the thrombophilia side. Now I'm going into some bleeding disorders. Let me just. Is my screen shared?
Yes.
Yes, it's coming up. All right. Okay. Now here on and off, I might have some questions for the students, and it will be nice if I can hear something. Since I'm seeing the entire screen and I'm not sorry, seeing the participants. So yeah. Just give me 1 second. 1 second. Right. So shall I carry on?
Sure, sir.
Right. So this case, this is our case 2. A 31-year-old lady posted for laparoscopic cholecystectomy. She's very apprehensive as she feels that she bleeds more from wounds. She has menorrhagia. She's on hormonal therapy, and she has gum bleeds for which she was given tranexamic acid. However, just 3 months back, she had a cesarean section delivery, which was her first pregnancy, and it was uneventful. Her paternal grandmother had similar symptoms. So this history, before going for the surgery, she informs the surgeon. So they do a BTCT, bleeding time, clotting time. It is normal. What happened? They take her up for surgery. So she's posted for surgery. She bleeds torrentially, converted to open cholecystectomy, required 6 units of blood and an additional 4 units of threshold blood, basically 20 units of blood required. So that's what happened to her. So something is wrong somewhere. So probably some part of the history or some relevant part of the history was missed out, or there was something wrong in the testing part of it. So let's look. So basically, to start off with, rather than all the tests that you can do in the lab, it is always good to have a history. Why? Because history is key to understanding and diagnosing hemorrhagic disorders, and without any symptoms, an abnormal coagulation test result really has no value. On the other hand, with a good history, you may just need some basic tests of hemostasis in the laboratory for making a diagnosis. So we were discussing that this lady has some types of bleeds, that she has epistaxis, she has menorrhagia, so gum bleeds, right? So when you have surface bleeds, such as mucosal bleeds, epistaxis, gum bleeds, urinary tract bleeds, DF tract bleeds, menorrhagia, or superficial cutaneous bleeds, skin bleeds, which means your petechiae, purpurae, ecchymosis, subcutaneous or superficial hematomas, or the history of easy bruisability. When you have any of these surface bleeds, you're actually thinking or you are dealing with a primary hemostatic disorder, which means there is something wrong with your von Willebrand factor or your platelets, either directly or something to do with the platelet glycoprotein in terms of addition, aggregation, or a secretion defect of the platelets. So surface bleeds, primary hemostatic disorder. So that's your primary platelet plugs. I will come to that a little later. And then you have deeper bleeds, when you have say muscle hematomas or pseudotumors or hematoses, which are finally letter of inspection deformity. When you have these deep bleeds, hematomas, hematosis, you're dealing with a secondary hemostatic defect or a coagulation factor deficiency. And these are some of the symptoms you would see in a severe hemophilia patient, hemophilia A or B. You can find these kind of symptoms. Why the secondary hemostatic? Why is it called secondary hemostatic? Because the primary hemostatic is the platelet, and it is an activated platelet surface, which is the ideal platform for your factors, clotting factors to come and do their job. So that is the forming the secondary hemostatic plug. Now, how do you know whether a bleeding disorder is mild, severe, or so on? So basically, when you talk about mild bleeding disorders, the symptoms are fairly infrequent, and the history of bleeding is only after trauma or surgery. And usually, there are only mild episodes of mucocutaneous bleed. Whereas when you talk about a severe bleeding disorder, it is more frequent. Spontaneous bleeding happens, that is, without a provocating event. There is no trauma, no surgery, no provocation. And this bleeding can be prolonged or even extensive. And if your bleeding episode requires a hospital visit, which means you cannot conservatively manage it at home, either with compression or some home remedies, and you need to go to hospital to get. I'm sorry, a whiteboard has appeared.
Can you share screen now?
May I resume?
Can you share your screen now? Yes.
Sorry, no, that was wrong.
The previous one, yes.
Yeah. Okay, I don't know what happened. Let me just. Is there a slide shared as of now?
Now.
No. Okay. Okay, it shows you're about to share. Okay, has it come up now?
Yes, now it is.
Okay. Yeah, sorry about that. So, yeah, I guess we were here. So, even if you have a single hospital visit for a bleeding disorder, then that's probably a severe bleeding disorder. And if you require surgical hemostasis to control the bleeding, or if you have blood or blood component transfusion to control the bleeding or to compensate for the bleeding, then you had a severe bleeding episode. Now, how can we objectively assess the bleeding history? Because it may be different from person to person when you take it. How can you objectify? For that, the ISTH, the International Society of Thrombosis and Hemostasis, has come up with a bleeding assessment tool, which is called ISTH BAT. The purpose is to improve the collection and reproducibility of the bleeding history. Each bleeding symptom is scored from 0 to 4. There are 14 categories of symptoms included, and the 14 categories include cystic, cutaneous bleed, minor wound bleeding, oral cavity, menorrhagia, surgery, tooth extraction, GI, hematuria, hematoma, hematosis, so on and so forth. So 14 categories, 0 to 4, and you give the score. It takes around 20 minutes to correctly administer this bleeding tool, but it's very useful. Now, let me try to show you. Now, for this ISTH BAT, there are some cutoffs to call it significant. Now, after looking at all the symptoms of the patient and scoring them, in a child, if the score is more than or equal to 3, it is significant. In adult male, more than or equal to 4 is significant. And in adult females, more than or equal to 6 is significant. Now, we must keep in mind here why the difference in the scoring, because in the children, the exposures may be limited, or the times they can have exposure because they are taken care of much more, especially in the babies. Adult males score, while adult females will obviously have the additional symptom of menorrhagia, so the score is on a higher. Now, we did a study at our center to look at how the utility of the bleeding score in identifying non-bleeders versus bleeders. And as you can see, even from the figure, that it is very clearly very helpful in identifying non-bleeders versus bleeders. Although between severe bleeders and non-severe bleeders, you probably couldn't tell a clear difference. But non-bleeders versus bleeders, clearly, that score was very useful. So this is what the BAT score chart looks like, which is available freely online for access. So you can see that the scoring is from 0 to 4, and all the symptoms are listed like that. And based on whether there's no trivial, give a 0 score. If it's a mild symptom, you give it a 1. And if there was a consultation only, or there was requiring antifibrillatory, depending on symptom, you give it a score. Okay, so now our particular patient had menorrhagia, which required some therapy, hormonal therapy, and then there was a complaints of bleeding, EC bruisability, which required consultation, and oral cavity, basically gum bleeding, which also required consultation. So the score is 2-2 for this as well as for the other one. So she has a BAT score of 6, and remember we had said that more than or equal to 6, a BAT score is significant in this person. Now for this particular case, or in fact for any other given case, let's try to answer some questions. One is, what is the BAT score that I've already given you? In this case, it's 6. Some of the other questions we should try to answer after getting a proper history is: 1, is the patient a bleeder or a non-bleeder? That should be one question. Once we answer that, if it's a bleeder, is it severe or mild? Once you answer that, can you tell us if it's a primary hemostatic or a secondary hemostatic disorder from the history, that is the superficial versus the deep? Then try to tell whether it is inherited or acquired. Remember, you will always take a family history as well. If you're saying it is inherited, can you try to deduce whether it is autosomal dominant, autosomal recessive, or X-linked recessive? And what is the likely diagnosis? I think you must have been already shared this kind of a questionnaire and an example scenario using a hemophilia case. So we'll try to follow this for our case as well. And this is where I will probably need your help. Okay, now this is where I hope to hear some answers from your end, right? So I've just put up the summary for our particular lady. There's a lap lady, lap cholecystectomy. She feels she bleeds more, etc. So she's very apprehensive for surgery. And she has a cesarean delivery, which was unable, but she has a paternal grandmother with similar symptoms. Now I've given you the BAT score, which is 6. What's your answer to this question? Is she a bleeder or a non-bleeder?
She's a bleeder.
Bleeder, agree. Fine, good. So this is what I want. I want this kind of feedback. Good. So she's a bleeder. Next question: mild or severe?
Severe.
Do everyone uniformly say severe? Now I want both groups to justify. The majority says severe. I'm not going to take names or anything, but majority has said severe. Can you justify why you said it's a severe bleeding? Any point that suggested that she's a severe bleeder? Okay,
Cutoff of 6 is great, sir. So it is a severe bleeding.
No.
And if you find a hospital visit, so that can be the reason.
Okay, that can be the reason. But coming to the BAT score, now see the score given here. Now it is significant if this is more than or equal to 6, which means if it was 5, it is not even a bleeder. This is the BAT score for telling the bleeding history. Are you a bleeder or not? So if it was 5, she would actually come under the category of a non-bleeder, so to say. And I would say, for example, if you have a hemophilia, hematoses, epistaxis, bleeding from open wounds, this, that, and all, the bleeding symptoms will even go up to 20. Now she's just, with all her symptoms, she's just sitting at 6. The other thing is, you have one history here. She even had a cesarean delivery 3 months back, which was uneventful. So do you think a severe bleeder will have a very uneventful cesarean delivery?
No.
So questions to answer. Yes. So actually, from the history, she has some superficial bleeding symptoms. Yes, no doubt. She has, but remember, she's 31 years old. She didn't have a very long history, and probably these mild bleeders even sometimes come to attention only when they attempt puberty, especially in the ladies. So puberty menorrhagia may be the very first symptom that this patient may have a bleeding symptom. Till then, they might be absolutely normal with no symptoms to show. Anyway, she has a very small or low BAT score at 6, which is significant. So we have to consider that she has symptoms. She's symptomatic. We have to consider that. And now we also know from the history that she bled on table torrentially after the surgery, not during the cesarean. So we have to discuss that as well. Anyway, she's a mild bleeder. Now, from her symptoms, is it a primary or secondary bleeding?
Primary.
Anybody has any other thoughts? But Primary, because you can see that all the bleeds are superficial mucosal or cutaneous bleed. So primary hemostatic defect. Inherited or acquired?
Inherit.
Slightly.
Inherit.
It can be both.
Okay, so justify both sides, either side. Okay, so somebody said, okay, majority said inherited. So why do you say inherited?
Paternal grandmother has similar.
Right. So there is one family history there which says the grandmother has similar symptoms. So that gives you a clue that probably it is inherited. Anything to say it is acquired?
She has undergone a major surgery just 3 months back, but that time she didn't bleed.
Hmm.
So the hormonal therapy can be the reason for this bleed.
Okay, so you're attributing it to
So
the
old age.
Sorry?
So adult age, the inherited bleeders usually start bleeding in the early ages, and this is a
Okay.
31-year-old lady, so it could be
That's
acquired
right.
also.
Right. Okay. Because she's 31 years old and we don't have any history from her past, so you can assume that it is that. But again, like I said, the thing here is that if you're a mild bleeder, then unless there is really a provocating event, you may not bleed. So then you might ask about the cesarean thing. We'll come back to that. So for all purposes, with this history, look at it straightforward. It is inherited. You have a paternal grandmother, but just that she's a mild bleeder, so she won't have many symptoms as we expect generally. Okay. Now, what is the mode of inheritance if it is acquired? Sorry, if it's inherited.
Like the autosomal recessive.
You say autosomal recessive. Okay. I'm hearing a dom as well. I think you're dominant, but I heard dom. Okay. Okay. Anybody for X-linked recessive? That is the last one. Okay, so I believe no one for X-linked recessive, so we'll keep that out because clearly it is not showing that pattern. We have a paternal grandmother. So now if the paternal grandmother is having symptoms and then there is somebody whom we do not know or hasn't presented with any symptoms, one generation above, which is the father probably, and then she has got the symptoms. Now if it was X-linked recessive, you would not find usually in the previous generation because you need two recessive genes to come together to get the patient have a disease. Also, you must have read about all these autosomal recessive bleeding conditions. Most of them are quite significantly symptomatic. This may be an autosomal dominant is a possibility here by virtue of ruling out the other part. Any DDs, any diagnosis or differential diagnosis as to what could be her condition?
Von Willebrand disease.
Okay, von Willebrand disease. Now, okay, let's keep that von Willebrand disease. Yes, okay, yes. Then anything else? It can be. Okay, right, great. Okay, you're not wrong. Platelet is also not wrong. Again, remember in von Willebrand disease you have there again it's going to be a primary hemostatic because the von Willebrand will not some reason not to attach the platelets very well. Anyway, so considering that it is autosomal dominant from the history, and most of the known platelet disorders that we have autosomal recessive, the well-known one. And okay, can you when you talk about von Willebrand disease, which von Willebrand diseases are? Okay, if you say this is von Willebrand disease, can you tell me it will be type 1, type 2, or type 3? Which among these can you exclude?
Exclude type 3, so that is autosomal recessive.
Very good. So if you can exclude type 3, but again remember you're not excluding type 3 because it's autosomal recessive. Because autosomal recessive means we have from our history of course telling you that it is autosomal dominant, but that way you can of course keep type 3 out. Also from her symptoms you have to keep type 3 out. One type 3 is severe. It's severe, exactly. It is a severe bleeding disease, so it's a severe bleeder would have presented much earlier, and this will not be the history you would expect from a von Willebrand type 3. So of course it is autosomal recessive and it will be a severe bleeder, so this is autosomal dominant. So your diagnosis here of von Willebrand disease is probably right. And so now we are left with type 1 and type 2. Both are possibilities here, and both can be autosomal and both are autosomal dominant. So that's where we're going to proceed. Now you can see that how history has helped us to come to this far, has helped us come this far. Now let's go with the lab result. So she has hemoglobin of 8.6, so she has lost some blood, and the total comes 6,500. Platelet count is actually quite normal. Now her bleeding time shows 8 minutes, right? And the normal reference range in my lab is 3 to 7 minutes. So there's some explanation of bleeding time here. So what exactly is bleeding time? It is time taken by a standardized skin wound to stop bleeding. So we are using this particular lancet to get a very standardized wound, which is around 2.5 millimeter deep and 1.5 millimeter wide. Then you use this lancet and the modified IVs method. So what is modified IVs method? You inflate the BT cuff to 40 millimeter mercury. You select an area of the aspect avoiding veins, angiomas, tattoos, scars, etc. You stab confidently 3 times and start the stopwatch at the end of the third. Why do you need 3 wounds? With the assumption that at least one of these wounds is a standardized skin wound. Remember, the bleeding time is a stab wound. So you know your technique is good when you can see blood welling up like this. Okay, you can see blood welling up from the wound, and then at every 30 seconds you blot it. You see the stopwatch is running, and every 30 seconds you blot it with the blotting paper. Now we have moved on from this standard this lancet that we were using to this particular safety lancet, the mini capillary sampling device from Briner actually. It looks like this. This is a trigger based device, unlike the other one where you actually physically have to stab. This is a trigger based, so the pressure applied is always going to be standard or uniform. The other thing is once you remove the cap and you puncture, once you inject or do this triggering the needle after puncturing it retracts inside, which means it reduces the chances of a needle stick injury. The other thing is you don't have to make 3 stab wounds because there is only one type of wound you can get with this because of that puncture, the trigger, and that we expect it to be a stab wound. The other thing is the edge of this has some counter irritant, irregular methods which will actually give some counter irritant effect that the actual stab of this is not felt. So it is a little more patient compliant as well. So lesser wounds and more patient compliant, less pain, much more user friendly and patient friendly. So we are using this now, and this could be, the skin bleeding time can be an objective measure. You can actually store the filter papers for the patient in a Ziploc file for future reference. It serves as a record. This is good test. Provided your bleeding at 30-second time point is good, you have the good welling up of blood, then it is actually a good test. You can actually monitor, keep this in a Ziploc file as a record of the patient's bleeding time. So the results for the bleeding time, you stop the stopwatch when all the wounds stop bleeding. Normally it's 3 to 7 minutes. Now remember, in your platelet dysfunctions or primary hemostatic defects, the bleeding time will not stop. That doesn't mean you continue this forever. There is some point that you have to stop. If not, the patient will bleed out. So that time point is 15 minutes. So until 15 minutes, if the wounds don't stop, you stop the test, and then you need to apply some compression or give some medical attention according to the situation of the patient. So it is ideal to establish your own reference range. It could vary from the lab to lab, and where you can get the abnormalities. Of the bleeding time, there is a defect in the primary hemostasis, formation of the primary platelet blood. So for example, if you have an adhesion defect as in von Willebrand disease, or Bernard-Solé syndrome where the glycoprotein is abnormal 1B, or an aggregation defect as in 2B3A glycoprotein abnormality Lanzmann, platelet secretion defect, gray platelets, or even drugs for that matter. Remember that in thrombocytopenia, you should not do the bleeding time in a patient who has less than 20,000 platelet count because this thrombocytopenia per se can prolong the bleeding. So in our particular patient, you said that BWD was your differential. So our plasma-based test went like this: normal PT. The APTT here was not abnormal in this particular case so much. So tromin time was normal, fibrinogen normal, factor VIII was normal. That's why probably your APTT didn't go for long. And 9 was normal. But look at your ustostatin cofactor activity. This is your 1 milligram factor activity, say 13.4%, and this is your reference range. So we had one abnormality which we picked up. So we thought from our history we had came to diagnosis, and it seems that we are on the right track. Now, okay. Now in a blood vessel, you have these procoagulants in the circulation. So in an intact blood vessel, factors will just keep flowing like this. No clot form. You can see you have your factors, your proteins, your platelets. You have your large 1 milligram factor multimers tagged with your factor 8. Isn't it? You can see. So this is your factor, cofactor, factor 8, and 1 milligram, the coil factor, and so on. And these are your platelets. So that happens. Now, when you have a breach in the endothelium, your subendothelial collagen is exposed. So initially, what happens? All these factors, including your platelets and all, start escaping. Obviously, there is a big pool, and this is what is your actual bleeding. You need to bridge this gap somehow. So that's when your coagulation cascade kicks in. So first, we start with the primary hemostatic flux. How that works? You need platelets to bind to the subendothelial collagen, and the mediating platelet is your mediating protein is your 1 milligram factor. So when your subendothelial collagen is exposed, your platelets will just keep going because directly they cannot bind to that. So the output of platelets continue. But then you have your 1 milligram factor, which is an adhesive protein, which is a large multimeric protein. So it's actually coiled up like this. This will bind spontaneously only to the exposed collagen. In circulation, nothing will happen, but if the collagen is exposed, it will bind to its A3 domain. Now, the interesting thing is, in this coil formation, there's another domain called the A1 domain, which is hidden. That is what actually attracts the platelets. Now, in an intact endothelium situation, you don't want platelets to come and bind to the 1 milligram factor and cause clot unnecessarily. So it is hidden. But when the collagen is exposed, this will roll out. So what happens will be, it will roll out like a carpet. This will now uncoil, and it will bind to the collagen through the A3 domain. And when it uncoils and binds to the A3 domain, now the A1 domain, the A1 domain is exposed. Now, this exposure of this A1 domain, that is what has affinity to the glycoprotein 1B of the platelets. It helps in addition. Now, remember, the blood is flowing. There's a good shear force of the blood. So fortunately, you have this long protein. Therefore, even with the shear force of the blood, the platelet is being pushed out, but still it will manage to find a good connection with the 1 milligram molecule, and once that happens, it will get activated. And once activated, there is a shape change, and it releases some factors which helps in aggregation of platelets. So initially, there is a shape change. This to platelet structure, which is more surface area. There is a flip-flop mechanism where the procoagulant platelets are brought to the surface from the bilayer, and the glycoprotein 2B3A is reorganized, which helps in the aggregation, and there's a granule. So what happens is this: initially that happens, but once you have the 1 milligram factor, now look at the situation. If you have a 1 milligram without large multimers, with a shear flow of blood, it is not enough for the platelet to come rest, attach, and activate. Before that, the flow of blood is pushing it away. So you definitely, when you have very short multimers, platelet addition doesn't happen. You need the long multimers. So how do you diagnose and classify 1 milligram disease? Now, there are the ASH, ISTH, WFH guidelines for this. I will not go into the details because it is available online. Now, there is a table given and a lot of checkpoints and points are given there. Now, just look at the very top. Patient suspect of 1 milligram disease. The first point is apply the bleeding assessment tool and then decide if it's positive or negative, and then negative you go to 1 milligram disease. So just to tell you the importance of the bleeding assessment tool, and then you go down. We'll not go into details here. We'll try to stick to our patient. Just to show you one of the rules that these people, that the guidelines recommend. You can see that when the 1 milligram levels are less than 30, as in our case, you look at the platelet-dependent 1 milligram factor activity to the antigen ratio. So there is activity, there is antigen. Look at the ratio. If it's more than 7, that means it is equivalent to 1, which means they are fairly equal. Then it's a type 1 milligram. So if there's no discrepancy between the functional and antigen assay, it is type 1. Whereas if the ratio is less than 7, then it is type 2 1 milligram disease. Discrepancy between functional and antigen, which is the qualitative defect. The recommendation number 8, there are several recommendations. I'm showing you the relevant one here for our case. The panel suggests against the platelet-dependent ratio activity antigen ratio cutoff 0.5 and rather using a cutoff of 0.7 to confirm type 2 1 milligram disease. Now remember, type 1 and type 2 is straightforward. Type 2, there is 2A, 2B, 2M, 2N, so on. So we need to try to subtype as well. So coming back to our patient, I showed you that the 1 milligram antigen was low, and the 1 milligram activity I showed you earlier was 13.4. The antigen was 31.2. Now remember, the cutoff you're looking for normal functional is 0.7, but the ratio here, the antigen to the activity ratio is only 0.43, which is clearly less than 0.7. So now we can come to a conclusion that our case is a type 2 1 milligram disease. Okay, but still the question remains whether it's a type 2A, 2M, or 2B. Now what are the subtypes? We need to know that before trying to eliminate these one by one. So the classification: you have a 1 milligram type 1, which is a mild disease, autosomal dominant. We already discussed type 3 severe autosomal recessive. And then you have these autosomal dominant types, functionally poor or qualitative. These are the type 2s. In type 3, no 1 milligram factor, therefore no platelet binding. In type 2A, this was one of the examples I showed you. You have absent high molecular weight multimers, which tells you why platelets cannot effectively bind. Although they are there, the domains are all fine, the binding is not possible, unfortunately. And then you have the type 2M, where there's an inability to bind platelets because the domain is missing. The length may be fine. So you have high molecular weight multimers, but probably the domain is missing, so it cannot really bind. So there is inability to bind platelets. That's 2M. Then you have type 2B. This is a situation where there's increased platelet binding, therefore increased clearance, and therefore there's clearance of 1 milligram factor and the platelets, and therefore you have a 1 milligram disease type 2B. Now the rare one is there, inability to bind factor 8, which is the normandy or type 2N, so to say. Inheritance, we have covered it. I'll not spend time because we are running out of time. So the screening test, we did the platelet count, APTT bleeding time. There's also another screening test, which is the platelet function analyzer. It is also a primary hemostatic test, which is looking at using platelet agonist on a appropriate treatment. I'll not go into details now. Your specific test for 1 milligram disease, you need to know the factor 8 levels, 1 milligram antigen, and activity, including collagen binding assay, and some discriminatory tests. If you have some of these, you can actually discriminate between 2B, 2A, 2M, 2N. Ustostatin induced platelet aggregation. So specific test, 1 milligram antigen, quantitative, and the remaining assays are all qualitative. I'll go a little fast because this is all a little theory, which you can read up actually. So antigen measures the total amount, and the amount this can be done by ELISA or latex or chemiluminescent platform. So RECOG is a functional assay that tells you about the 1 milligram supported agglutination of normal platelets. So you use ustostatin, which helps do that. Ustostatin binds 1 milligram factor, induces the conformation change, and helps to bind platelet glycoprotein 1B, causing the cross-linking. This is dependent on the presence of high molecular weight multimers and an intact glycoprotein 1B site. Only these two are intact, and you get a normal ustostatin cofactor assay. Collagen binding is, as the word says, looking for the ability of the 1 milligram factor to bind to collagen. Okay, so that this is based on an ELISA platform. How do you interpret that? It's depending again on high molecular weight multimers and an intact collagen binding site. So if you have these two intact, your CBA should be normal. So how it's usually helpful is that this collagen binding assay can be distribution between 2A and 2M. Whereas in the latter, in 2M, you have normal high molecular weight multimers, so the collagen binding assay will be normal. But in 2A, like I showed you, you have these multimers which are short, therefore the inability and therefore collagen binding assay will be abnormally low. Then there is ustostatin induced aggregation, where you test the individual CRP for sensitivity to ustostatin at various concentrations. So in type 3, you have no response at any concentration because there's absolutely no 1 milligram factor. Type 1 will depend on the 1 milligram level. Type 2A will depend on the 1 milligram activity. Now, the platelet aggregation, for that, we're going to do platelet aggregometry that I'll probably go to the next stage and show you. But there is type 2B. This is a different pattern in the sense there is an enhanced aggregation with low dose ustostatin. Normally, even the normal platelets like yours or mine, with low dose testosterone, there will not be any aggregation at all. So after the aggregation, the low dose testosterone is the norm, whereas in 2B, because of increased platelet binding, there will be aggregation. So that helps to rule in or rule out the type 2B. So for example, you have a patient here under control, you can see this is platelet aggregation normally with testosterone, and the patient is showing no response in von Willebrand disease. But when you add cryoprecipitate, it compensates for the absence of von Willebrand factor, and you can see a response. So that tells you that there was absence of von Willebrand factor. Now in von Willebrand, you can see that in type 2B, for example, this dark black line is the control, which will not give you a response with type 2B, but which will give you a response with all the other platelet agonists that can activate platelet collagen, testosterone, normal dose 1.5. This is low dose. ADP, epinephrine, these are all platelet agonists, and you can see normal response for the control and the light color of the patient showing all the same response. But when it came to testosterone low dose, control is showing no response, which is normal, whereas the patient is showing increased response. That happens only with type 2B. Now in our patient, we showed you the activity, we showed you the antigen and the ratio, we showed this, and now I will show you the testosterone-induced platelet aggregometry for the patient. You have even the normal dose testosterone, this is the control, and reduced response to normal dose testosterone, and the low dose testosterone, both the control and the patient is showing an absent response. So can you tell me from these three which one you can eliminate now? Can you eliminate any of these with this information? So even our patient on testosterone-induced platelet aggregometry is not showing a response to low dose testosterone. So had it been type 2B, you would have got a response to low dose testosterone. So we are actually going to, with this information, we have taken out type 2B. It is definitely not type 2B. Reduced response to normal dose testosterone, absent response to low dose. So now it is the 2A versus 2N. So what we can do next is look at the collagen binding index. Here it is 9.7, while this is the normal range. So you have if you look at the ratio of collagen binding to the antigen, 31.2. If you look at the ratio, it's significantly low. This is anyway definitely a low number. So with this, we come to the diagnosis that it cannot be a type 2M, where the collagen binding has to be normal because there is high molecular weight multimers in the system. In a type 2A, you do not have high molecular weight multimers. Therefore, collagen binding is going to be abnormal. Therefore, we have actually excluded one more, which is type 2M, and we have come to a conclusion that this is type 2A von Willebrand. So this is how we have gone on from the history, VASCO history, trying to come to a diagnosis even before doing the test. Then based on each test, we go further and try to come to a diagnosis. So I'm completed this case. I know it's 8 o'clock. I do have one more case. If you permit me, I will try to complete that faster. Before concluding this case, I have one question. I've highlighted 2 points here, which I would like you to answer. Now, can you tell me, this patient went in for a lab cholecystectomy, which tells us that she had choroidal acid. So, from your knowledge, from your past, do you know what are the factors that could have promoted choroidal acid in this patient? You know some mnemonics that might lead to the answer? Anything? Sorry?
Dr. Donut Nishkala?
What came out was not clear, so could you please repeat it?
Sir, people are answering it. They're saying 5.
Yes. Okay, I see now. So I'm not seeing the chat box actively because my screen is fully occupied with the presentation. So if somebody can read out some of those things. I did see the fat fertile female.
Right.
Yes, so female 40 fat. Yes, so this is what we all know. So yes, fair, that's correct. So the 5 F's that we know of, female fat fertile 40. Now remember, this is not 40. We don't know if she's fair or she's fat. But just sorry, out of interest, if you look at the 20th edition of, I think, Bailey and Love Surgical Textbook, they mention it in a little different way. They say postpartum, they say, I think 7 P's. Postpartum primary parous lady who was a pre-pregnancy pill taker. So postpartum primary parous pre-pregnancy pill taker. So you know she was on hormonal therapy. You know she's postpartum. I did mention that was her first pregnancy. So probably those categories also fit in here. Now my next question: she had a cesarean delivery 3 months back, which was uneventful. Of course, we have said that she's a mild bleeder, but still, do you have any justification for why she didn't have bleeding symptoms or sign during that delivery?
So because in the pregnancy there is increased production of coagulation factors, and maybe that's why.
Absolutely right. So that is the reason. That is why now she has gone for surgery and that to a lab cholecystectomy and she's doing torrential. But during that delivery, what happens? You're right. Pregnancy is a post-traumatic stage. All the factors. If you cut off 500 50 to 400 in pregnancy, you need a minimum cut off of 200. That's what you'll keep even patient bleeding. Similarly, your factor rate is going to be high. Your von Willebrand factor is going to be equally high. So all these levels that you see her, when all the levels during her pregnancy, they have well compensated her, and therefore she had a smooth pregnancy. Very good. So that was the right answer there. So we have answered those 2 questions in this particular case. Right. Can you give me some more time to go ahead to the next case? Moderators?
So please.
Oh, okay, good. Thank you. So this is the last case. So let's just try to go through this as well. 6-year-old girl presents with gum bleed. History of bleeding from immunization site. Epistaxis requiring packing and tranexamic acid. 1 episode of melina. Born to secondary transplant with his parents. Has a year-old male sibling. 1-year-old male sibling with similar problem. Okay, so let's try to chart on that scope. We know nothing from this table. Yeah, no hematomas or nothing. Epistaxis, which required packing and some cutaneous bleeding, which has consultation. Oral cavity, gum bleed, consultation. Melina, consultation. So you can see the score coming for 2 into 3. That's 6 plus 3, 9. So the back score here is 9. You know that in a child, anything more than or equal to 3 is significant. So I've already given you the back score.
So we can't do.
Yeah, sorry, I think it was muted for a second. So let's try to answer these questions quickly. Bleeder or non-bleeder?
Bleeders.
Absolutely, yes, bleeder, no doubt. Mild or severe?
Severe.
Severe, sir.
Yeah, I think we are all agreeing on that. It's a severe bleeder. Primary or secondary?
So primary.
Secondary, sir.
Why?
Mm.
Looks like we don't have a consensus here. So see, gum bleed, superficial bleeding. Bleeding from immunization site is a cutaneous bleed. Epistaxis, superficial bleed. Melina is also a mucosal bleed. Melina is a mucosal bleed. We have all superficial cutaneous or mucosal bleed only here. So
Primary.
yeah. Primary mistake. Inherited or acquired?
Inherited, sir.
Why?
Because of the history of community as well as the sibling problems.
And a sibling.
Absolutely. What have inherited?
Autosomal dominant.
X-linked.
Okay, so we have autosomal dominant, we have X-linked, and one more. Okay, so now we are complete with the trial. Now how do we decide which one this is? Now, one clearly I can exclude. Which one you can exclude?
Excellent.
Yeah, you can exclude the X-linked processes. See, if it was X-linked or primary, or index case itself is a girl. Unless you have those rare situations where, you have those lionization or homozygosity or things like that. Very rare to have that. And so you have a male and a female sibling here. For now, you keep out the X-linked. Now you have autosomal dominant recessive. Now, like the previous case here, you're having two siblings, so you might tend to think it's a dominant, but remember, we don't have any other family history here. All we have is that there is consanguinity. And we have nothing to say that the parents are symptomatic. We assume that the history includes the parental history, family history, everything. So it has not gone, the symptoms have not gone, it's not from anywhere outside this particular small nuclear family. It is somewhere sitting there. So this has to be an autosomal recessive where the parents might have some half abnormal gene which they have given to both of these children, and they seem to be asymptomatic. And and also the fact that there's a consanguinity here, the fact that there's a consanguinity, that is where we actually have most of these recessive disorders being transmitted. So we go on those lines. I know there's a query of dominant recessive, but I hope my explanation makes sense. So we keep it as autosomal recessive, and then you have to give me a diagnosis. Possibility studies. Beliefs.
So could be platelet disorders.
Okay, it could be a platelet. We are dealing with the primary hemostatic, probably autosomal recessive.
This is
I see in the chat box a severe VWD has come in, but then a severe VWD. Okay, so you're saying that's the autosomal recessive on type 1. Right, I think we're good to go. Perfect. You guys are very good. See, exactly what you said. I have nothing more to add. Right, okay, let's go ahead. So the lab results for this patient, hemoglobin there, 9.6, total count there, platelet count. Okay, now you have a bleeding time, more than 15 minutes, huh? So we had to stop the bleeding time, the patient kept on bleeding, so that's there. But look at the platelet count is very normal, so we thought, okay, count whatever normal, look at the smear as well, morphologically also normal, so you have nothing there. And okay, let's say from this much now, do you have any more, you have any specific things to comment on? Any thoughts?
So the glands from the large platelet.
You're saying glands from large platelets may be seen, but I do not have large platelets at all.
Yeah.
So you're telling me you're ruling out glands, is that what you're telling me?
Yes, I think so.
Okay, let's keep that on the back burner there. There was one factually wrong thing there. Anybody else, any other thoughts on this? No, I really appreciate your answer. I want you to answer. I want more to come out. That's very simple. Rule out BS. Okay, so BS, I assume by BS you mean BSS, Bernard-Soldier syndrome, am I right? Okay, I can't see the meaning of that chat. I assume, yes, there's a BSS. Right, okay, fine. Okay, so now we have BSS to be ruled out, and one person has said that Glanzmann to be ruled out. Now, can anyone tell me from anybody else who did not put these 2 points, why you can rule out a BSS right away? Anybody?
Platelet count will be decreased in Werner syndrome.
Very good. That is true. Anything else about the platelets and BSS?
Giant platelets.
Absolutely. So BSS is the case where you have macrothrombocytopenia, which means you can never have a 237,000 platelet count, and your platelets on the smear may be large and giant, including as well. Okay, so you have macrothrombocytopenia. So BSS is essentially ruled out. Now, anything for GT? Follow again. Okay, we'll keep that. We'll come back. So the bleeding time is long. You have a normal platelet count, normal morphology. Yeah. Now look at all your plasma-based tests. I will not waste your time, so I will just tell you that essentially you look from top to bottom, everything is normal. Now remember, we have one of our DTs as 1 milligram type 3. Now there you should have both a factor 8, which is out. That didn't happen. You have normal APDT, normal factor 8, as well as a protostin cofactor, which is normal. Therefore, you have essentially ruled out 1 milligram. Okay, type 3 or 1 milligram is out. So you are left with your platelet. So next test we can do to go ahead to see once you've done your plasma-based test with your platelet aggregometry. Now I did mention platelet aggregometry briefly in the previous case, but for those who are not very familiar with it, I'll quickly go through the principle. It's based on spectrophotometry. Basically, you have your platelet-rich plasma, which is prepared by light centrifugation of your circulated blood. So the principle is basically this: your platelet-rich plasma, you have a blank, which is used as a control where you have 100% light in, should go 100% light out. Where there is PPP, platelet-poor plasma at a blank. So light transmittance, this is light transmittance aggregometry. So light transmittance 100% in PPP. Now our interest is the PRP, platelet-rich plasma. So platelet-rich plasma in your this particular equipment, there's a magnetic curve at the bottom which ensures that your platelets are in circulation. All right. So the platelets will remain in circulation as long as there is a lot of platelets. And then because the platelets are in circulation, the light cannot transmit. The plasma very turbid. Light transmittance is very minimal or negligible as long as platelets are in circulation. Now next, what you do, you will add an agonist, any platelet agonist. It's a strong agonist or weak agonist. It can be ADP, epinephrine, arachidonic acid, collagen, protostin. Just like you mentioned, you add the agonist. Now, if your platelets are very normal, then the agonist will activate the platelets, and when the platelets activate, what happens? They aggregate, and once they aggregate, they settle down to the bottom. Once the platelet aggregates and settle down to the bottom, what happens to the light transmittance? It increases, and that increment is obviously proportional to the clearance of the aggregation of the platelets, because as more the platelets aggregate, that is the clearance of the transmittance of the light happens. So that is measured in a graphical form. So you're supposed to get a graph which looks something like this. You have your time and you have the percentage of the aggregation. So you're saying platelets are always going to be a baseline, nothing happening. That's a stable baseline. Now when you add an agonist, now is when the changes happen. So this is what normally happens. So one, there's a shape change. When the shape change happens, you'll get the sudden bulge here. And then now as the platelets start primary aggregation, you see this going down. That means the light transmittance is increasing. So the graph is going down. Then after the primary aggregation, this platelets secrete the contents, alpha granules, dense granules, etc. So that leads to your secondary wave actually. Okay, this bulge here is due to the secretion. And then you have more platelets. This secretion leads to more platelets aggregating. That's your secondary wave. So you have your shape change, your primary wave, and your secondary wave. So if you look at normally, if you have a normal sample like yours or mine, if you do platelet aggregometry, it will show aggregation with ADP, with collagen. Epinephrine, you will see these two phases very clearly because it's a weaker agonist and it takes its own sweet time. Otherwise, you many times don't get to see the primary wave and the secondary wave. In good strong agonist, you will only see the primary wave like that. The arachidonic acid, just like I mentioned in the previous case, low dose protostin normally should show no response, and normal dose of high dose protostin will give you a response. That is how we could eliminate 1 milligram type 2B, where even this one will show a response. Now, we have some DDs here like BSS, DT, etc. In BSS, Bernard-Soldier syndrome, we know that or in BWD, we know that there is a problem with platelet adhesion. So platelet does not adhere to the substitute collagen with protostin. Therefore, even with high dose protostin, you will find no response. Whereas to all the other agonists which are responsible for aggregation, usually have no problem. But protostin will not. There will be no aggregation. I mean, no response to protostin at all in BSS of 1 milligram. Whereas in Glanzmann thrombocytopenia, what happens is you have a very classical pattern which is called aggregation followed by disaggregation or cyclical aggregation of protostin. Low dose protostin is not going to give any response, and it will have no response to any other agonist. Why? Because here the defect is in glycoprotein 2B3A, which is responsible for platelet aggregation. So no agonist here is going to help you get you any aggregation because the glycoprotein 2B3A is absent. So you get flatline with all agonists except protostin, where there's aggregation followed by disaggregation. And in BSS of BWC, normal response to all agonists except protostin. With this, let's look at our patient. So in our case 3, you have this is your collagen. Your control is here. Your control graph is going, you can see collagen is strong and control graph is going straight up, whereas your patient is not showing a response. Epinephrine, control is showing straight up, patient no response. ADP, control straight up, patient no response. Rostastatin, normal dose rostastatin, control is showing a good response, patient is showing a response, then it is disaggregated. Then showing a response, it's disaggregated. So now do you have a diagnosis?
Segregation disorder.
So it's a blank lens thrombopenia. So there you are. So now we summarize the investigation so far. We have no problems here. Now remember, in a blank lens thrombopenia, the platelet count can be normal. The morphology is also expected to be normal. We do not expect any abnormality. So by looking at the platelet count or the sepsis, we may not see the blank lens. We need some other screening test like a bleeding time or the platelet function and like a test. You can see that all these tests are normal here. Hygrometry is showing a very specific pattern, and therefore your diagnosis, like you said, is blank lens thrombopenia. Now, can we be absolutely conclusive and be done with it and give a diagnosis? You're wrong. You already know the diagnosis. How can we be more conclusive? How can you have a confirmation? So you do a confirmatory test, which is platelet surface glycoprotein expression by flow cytometry. Okay. So yes, absolutely. So you do the platelet surface antigen markers. So basically there are these platelet markers like CD41, 61, 42B, 42A. These are specific for 2B, for 3A, and for 1B. You can use them as dating markers as well as to determine. So now our interest when it comes to platelet dysfunction disorders are mainly, like you said, is always usually not always between a blank line and a burden soldier and all, etc. And when you have a burden soldier, if your platelet count is really low, then your hygrometry may not be very easy to interpret. Your bleeding time may be prolonged because of the thrombocytopenia. So then you actually need flow cytometry to give you that confidence of calling it a burden soldier. So now for example, in our lab, we use CD41 and 42B because as you can see, 42B will cover for glycoprotein 1B, which is the additive protein, which will help you diagnose with a BD as well as a burden soldier syndrome. Whereas 41 is for type glycoprotein 2B, which is actually helping you diagnose the gland cell thrombocythemia part because of the deficiency in 2B3A. So already from this much of the testing, we know that this is going to be a case of gland cell thrombocythemia. So clearly, you cannot use CD41 as a gating marker because it is going to be absent. We assume by our knowledge already. So we will use CD42B, which is for gland cell glycoprotein 1B9, which is the adjacent protein. This is going to be normal here. So using this, so if you take a normal, we can use the platelet. So in a normal patient, not normal patient, normal control, we always do it along with the control. In a normal control, if you use CD41 and 42B, you expect to see 100% expression of your platelet, or 100% of your platelets showing expression for both 42B and for CD41. You look at it in the scatter plot form or the histogram form, you will find that there is 100% expression in a control because we are going to run a control along with the sample. Now in our particular case, when we did this same experiment, of course we gated here with. We obviously use CD42B for gating because we know only the glycoprotein 1B is normal. You can see what happens instead of having anything here. What you expect, as you expect to see in this particular case, you see 100% expression of CD42B and completely absent expression of CD41, which tells you that the glycoprotein 2B3A is not expressed at all. We can see here 42B 100% expression and complete absence of CD41. Now, in our lab, we usually don't stop here because remember the question of how they got it dominant resistance. So what we do, if you look at it always in flow cytometry, we can look at it from the MFI point of view. For example, in this case, if you look at this with 42B, the MFI, the median fluorescence intensity is around 33. You can see the X median for CD41 is only 0.2. So 33 was 0.2 like that. So anyway. For the control, we always find it along with the control. When you gauge your platelets using CD42B versus forward scatter, there is normal expression of CD41. The MFI is 28.3. Whereas in your case, our case 3, you can see that using the same marker for gating, there is absent expression of CD41. Look at the MFI, 0.2, 20 and 0.2. Now, the additional thing that we do in our lab is if really young children come, usually they are accompanied by the parents. If they are accompanied by the parents, we will also take a parent sample and do the same testing just to see what is the level of expression. Remember, neither of them are symptomatic at all. They are two asymptomatic. Okay. Now look at this. You have no other control is expected to be on a particular day. Who's the control? That's what we stand. This is the patient plan. And then look at the parents. Both of them have reduced expression of CD41. So both of them are actually asymptomatic carriers in this particular case. Okay. They both have probably one abdominal gene, and they're given to both their children. Both the abdominal genes have gone into both the patient and the sibling, and that's why the patients are landed at the disease first, which is actually indirectly proven without doing any molecular or genetic testing, just by seeing that MFI there's reduced expression of all the platelets for that particular glycoprotein in the pair. So with this, you have confirmed that your diagnosis is gland cell thrombocytopenia in the first place. I think just to complete for completion's sake, our diagnosis part is completed. So you have your diagnosis for the case here, but there are some ancillary or supplementary tests in the lab that will help you come to a diagnosis. I will not spend much time on this because already I know we have exceeded the time. So you have some of you may be familiar with this global test such as rotational thromboelastometry or thromboelastogram. So they actually give you, they're basically just two different platforms. Therefore, they will give you different parameters like R time on one CT on the other, K time, CFT, so on and so forth. But the thing is, unlike your PT or APCT, which is giving you an endpoint at the beginning of the plot, this is telling you the entire plot dynamics from how the plot is formed, and then what is the what is the plot strength, and what is the stability of the plot over a period of time. And for example, this part is by all the parameters, all the platelets, all the plotting factors in 25 nogen, and this is by the platelets. And your MCF, maximum amplitude or maximum plot firmness, is by both platelets 70% and 20 to 25% by 5 nogen. And then it will also tell you if there is any lysis happening. Now, how this helps us in the lab is that, for example, this is what a normal graph should look like. Okay, you start initiating the plotting process, and then you get a graph like this, and this is showing you the plot strength. Now, in blank cell thrombocytopenia, as you can see, I already told you this maximum amplitude of plot firmness, this part is actually determined by 70% to 80% by the platelet. Now, look what has happened in blank cell. That's not a very thin remnant thing because that's all the platelets are helping you out with. Okay. Similarly, just to tell you, this is useful in multiple conditions. For example, if you have hemophilia, right? This is what a severe hemophilia could look like. The clot takes a long time to clot, and the clot that is formed is also a very sluggish clot. Now, also you can differentiate between the phenotypes of hemophilia. For example, this is severe hemophilia, this is moderate hemophilia, this is mild hemophilia. You can see how the clot strength shows the improvement from severe to moderate to mild. That's telling you that it's actually telling you in real time what is the strength of the clot in that particular individual. And that's not done. For example, this case. You can see that the clot has formed very well, right? It has formed very well. There's a good thickness clot. But what happens after a point of time? It's converging. That's telling you that what does it tell you? That the clot has started to lyse. The clot shouldn't lyse. So that's already giving you a clue that you're dealing with a case of factor 30 deficiency probably, and then you can actually guide you to doing the specific test. So we have some ancillary tests in the lab that will help you in the diagnosis of diseases as well. So I guess that was my last slide. So thank you all very much for your attention. And if you have any questions or any comments, I'll be happy to take them up.
Yes, it is it. I can see no more questions.
Okay, then with your permission, I'm going to stop the screen sharing. Is that fine?
Yes, sure, sir.
Yeah, but I'm not getting to see the audience. I was only seeing my screen so far the presentation, and I think I will try to stop my video now. I have to stop
All of you are praising you for such a nice presentation, and thank you for taking us through such beautiful cases ranging from thrombophilia to one brand to gland cell thrombocytopenia. So thanks a lot, and thanks all the attendees and all the that participated. So I guess Rajesh, sir, do you want to say something?
Upcoming slide seminar on 18 June, polygonal cell rich regions, optimal approach by Dr. Nita Goldman. Thanks for attending. Please do upload for Telegram group. Please scan it and you will redirect to join the group.
Sorry if I intervene. I just saw one question in the chat box. It says, are there any findings that point towards GT on the peripheral smear? Unfortunately, no. That is where the challenge comes in. You might find a very normal peripheral smear. Normal platelet count, normal platelet morphology. You may not really have any specific clues from the peripheral smear that point towards GT. BSF, yes, like you said, thrombocytopenia and giant platelets, macrothrombocytopenia. With the caveat, we should keep in mind being that that from the central to northeast population of India, you must already be knowing there is a constitutional macrothrombocytopenia. So in those patients, we by default, that is in say Jharkhand, Bengal, Bangladesh, they have patients from those regions. They will have macrothrombocytopenia, which is constitutional, which is absolutely normal for them. They are not going to be bleeders at all. So for example, why I'm saying this is when this question was asked, we recently had a GT, a glandular thrombocytopenia, whose platelet count was when it came to that was about 80,000 all. That's it. But the patient was from Jharkhand, and if you look at the smear, there are giant platelets, large platelets, and the platelet count here was a little larger because impedance-based counters will underestimate the platelet count when you have larger giant platelets. So still it was not high or normal, it was around 120 to 135,000. But that case was a GT, it was a glandular thrombocytopenia. So like I told you, glandular thrombocytopenia will have a normal peripheral smear, normal morphology of platelets. For that particular patient, that particular platelet count and morphology was normal. So that's what I just want to highlight at this particular point.
Okay, thank you.
So if there are no more questions, I really enjoyed taking the session. Thank you all for your interactive session because that was the most interesting part for me, hearing all the